Hello, this is Kay Afchi, and I am taping the lecture for the nursing care of patients with disorders of the lower GI system. A hernia occurs usually because of lifting heavy objects or chronic coughing or straining to have a stool or voiding. And what happens is the part of the intestines protrudes through the abdominal wall. There are different types of hernias. The reducible hernia, when that happens, the protruding organ can be returned to its proper place by just pressing on the lump and it goes back into place. The irreducible organ is tightly wedged outside the cavity and cannot be pushed back through the opening, so it's kind of stuck there. If the organ is not replaced and its blood supply is cut off, it is said to be a strangulated abdominal or inguinal hernia, and then that's an emergency situation. Surgery should be done. Signs and symptoms of a hernia: there's an abnormal pouching or a lump outside the abdominal wall or in the groin area, and when lying down, oftentimes the lump kind of disappears. It can cause bowel obstruction if not reduced because of the incarceration or irreducible problem that occurs. Some discomfort may accompany the hernia. Pain especially occurs when the peritoneum becomes irritated or if the hernia becomes incarcerated or strangulated. In this case, it's an emergency because the blood supply is restricted and part of the intestines may die. Okay, the surgical procedure that's used in the treatment of a hernia is called a herniorrhaphy or a hernioplasty. If the area of weakness is very large, a hernioplasty is done. In this case, the hernia is reduced and put back into place, and then there's like a mesh type of material that's sewn over the defect in the abdominal wall to reinforce the area so that the pouching can't occur. There is a potential for complications because of the foreign object being implanted into the body, but the studies have shown that the recurrence of a hernia after a hernioplasty is reduced significantly. It can be done as an outpatient basis or via a laparoscopic procedure, and local anesthetic can be used. Otherwise, if the defect is small, the defect may just be closed with a matter of a few sutures. As far as the nursing care after hernia repair, basically nursing care is directed at controlling pain and preventing the reoccurrence of the hernia. So the patient is cautioned not to do any heavy lifting, pulling, or pushing that increases abdominal pressure. On occasion, an intestinal obstruction may occur. The different causes of intestinal obstruction would be, again, a strangulated hernia, or as a result of a tumor, a paralytic ileus, a stricture, a volvulus, otherwise known as a twisting of the bowel, an intussusception, which is the telescoping of the bowel into itself, or because of postoperative adhesions. Mechanical obstructions, examples of mechanical obstructions would be like a volvulus or an intussusception or a tumor or something that's actually mechanically blocking the intestines so that stool cannot go past. A non-mechanical obstruction would be, an example of that would be like a paralytic ileus, where the intestines is not working, it is just basically stopped functioning, and therefore there's no peristalsis to carry the stool, etc., through the intestines. So here we see, some examples of bowel obstruction, complications that can occur. Fluid and electrolyte imbalances and metabolic alkalosis can occur mostly because the patient, because there's no movement of the stool through the intestines, the abdominal or the stomach acids, etc., build up, and eventually, because they can't pass through, they come out and the patient has an emesis. And with continual vomiting, it gets rid of the hydrochloric acid, which is, of course, acidotic. So the patient becomes alkalotic because they're losing so much of their gastric secretions with their emesis. It also has an impact on their electrolytes because they're losing electrolytes through their emesis. Another complication, if not corrected, is gangrene can occur, or perforation of the bowel itself because of the buildup of stool and matters such as that. With the mechanical blockage or paralytic ileus, the higher the obstruction, the quicker you're going to see symptoms. Again, they're going to experience vomiting. The emesis that they have may actually have a fecal odor to it. You'll also see abdominal distension. They'll complain of constipation with failure to pass flatus. And the bowel sounds will be silent past the area that's obstructed. You may notice high-pitched bowel sounds at first, and then it'll go silent. So there may be a few bowel sounds above the obstruction, nothing below, because nothing's passing through. Or in the case of a paralytic ileus, you won't hear any bowel sounds. Now let's look at ulcerative colitis and Crohn's disease. The pathophysiology is inflammation and ulceration of the intestinal tract lining. The exact cause is not known. Possible causes are infectious agents, autoimmune reactions, allergies, heredity, and possibly exposure to some foreign substances. With ulcerative colitis, the inflammation typically begins in the rectum and gradually extends up the bowel toward the cecum. The progression of Crohn's disease is different in that it can affect any area in the GI tract. Signs and symptoms for ulcerative colitis: diarrhea with frequent bloody stools. So they can have up to 20-some stools a day and they can be bloody. And they also complain of abdominal cramping. With Crohn's disease, if the stomach and duodenum are involved, symptoms include nausea, vomiting, and epigastric pain. Involvement of the small intestines produces pain, abdominal tenderness, and cramping. So how do we diagnose ulcerative colitis and Crohn's disease? Often this is diagnosed during a colonoscopy or a flexible sigmoidoscopy, where they all identify the inflamed colon. They may do a biopsy when they do their scoping. On some occasion, they may do a barium enema. If the colon, though, is too friable, they won't put the patient through a barium enema because it could risk, perforation, something like that. They can do a stool analysis. Complications of the disease: there's hemorrhage. There may be an obstruction or a perforation. Abscesses may develop in the rectum or the anus, as well as fistulas or maybe even a megacolon. Medical diagnosis is done, of course, based on the results of the diagnostic tests, but also based on their history. In some cases, they can swallow a video capsule. I don't know if you guys have heard about that, where it can actually take a picture of the whole GI tract as it passes through the GI tract and comes out in the stool. Medical treatment involves medications, diet modifications, surgery in some cases where they may have to do a colostomy. That's oftentimes related to ulcerative colitis more so than Crohn's disease, because Crohn's disease affects so many different patches that if you do a colostomy, in one section, that doesn't mean that they won't have other areas of Crohn's disease throughout the rest of their intestines. So usually they don't do a colostomy for the treatment of Crohn's disease. In this slide, you can kind of see the difference between ulcerative colitis and Crohn's colitis, where the ulcerative colitis starts in the rectal area and moves up the intestines. Crohn's colitis actually is very patchy areas of inflammation. Again, it could develop into strictures and things like that. Again, treatment for these conditions may involve administration of anti-diarrheal drugs, long-term sulfasalazine therapy, and medications to relieve abdominal cramping. It's recommended that the diet consists of low-fat, low-fiber foods that are high in protein and calories. Small, frequent feedings are probably the best. Lactose avoidance helps some patients, decreasing their diarrhea bouts. Corticosteroids are used for moderate to severe problems with these diseases to help decrease the inflammation. During acute attacks where they're having a lot of stooling, fluid replacement may be necessary, so they may be on IV infusions. Blood transfusions are given if anemia is present. On this slide, I just included this so that you can kind of see the comparison of the symptoms of Crohn's disease versus ulcerative colitis. Crohn's disease is on the left, ulcerative colitis is on the right. With Crohn's disease, it can affect the entire intestinal or GI intestinal tract. It has skip lesions, which are primarily located in the small intestines and colon, most commonly in the terminal ileum and the cecum. Rectal involvement is uncommon. You can see with the depth of inflammation that the depth of inflammation is more superficial. And occurrence of fistulas and strictures. Fistulas are more common with Crohn's disease, and also strictures are also common with Crohn's disease. Now with ulcerative colitis, presenting symptoms again, abdominal pain, rectal bleeding, and bloody diarrhea. Actually, they found that cigarette smoking is somewhat protective in a case of ulcerative colitis, which I thought was kind of interesting. The disease is limited to the colon. The pattern is continuous. It originates in the rectum and progresses proximally. Rectal involvement is very common. The depth of inflammation is much deeper. And the occurrence of fistulas and strictures are very uncommon in ulcerative colitis. Here again you see the treatments for ulcerative colitis. We treat it conservatively. It varies depending upon the severities of symptoms. We look at the low-fat, low-fiber, high-protein diet, the small frequent feedings, the avoidance of lactose, the use of corticosteroids, and then fluid replacement and or blood transfusions is necessary. The expected outcomes, things that nursing is focused on, is controlling the patient's pain, helping them to regain their fluid balance, helping them to experience decreased number of diarrhea bowel movements within 24 hours. And the long-term goal for our patient care would be concerned with helping the patient adhere to the prescribed regimen, encouraging effective coping mechanisms, and participating in the prescribed psychotherapy. Let's look now at cancer of the colon. Most who are at risk include those who have disorders of the intestinal tract, especially people who have ulcerative colitis and or familial polyposis. Other risk factors are smoking, alcohol consumption, physical inactivity, obesity, a diet high in saturated fat and or red meat, and inadequate intake of fruits and vegetables. The pathophysiology of cancer of the colon. The cancerous tumor tissue may be from polypoid or protruding into the bowel lumen, or it may be involving the anus and extend around the bowel, causing stricture. Most large bowel tumors are adenocarcinomas and are believed to arise from polyps that protrude from the mucosal surface of the bowel. Then the tumor may spread into surrounding structures via the lymphatic or via the bloodstream. Signs and symptoms of colon cancer. Any change in bowel habits, either diarrhea or constipation, could be a sign of colon cancer. Now, the diagnosis is made based on screening tests. Okay, the screening tests include either an annual stool for blood or a fecal immunochemical test or a stool DNA test. Beginning at the age of 50, it's recommended that the person have a flexible sigmoidoscopy every 5 years, a colonoscopy every 10 years, and a colonoscopy is recommended in the case of any screening test coming back positive. So if they find, they do a test for stool for blood and it comes back positive, then they would do a colonoscopy. The carcinoembryonic antigen, it's a blood test. It'll be elevated in 70% of the patients that have colorectal cancer, but it's not really specific to that type of cancer. So it could be elevated because the patient has cancer somewhere else. So what we use the carcinoembryonic antigen for is to determine if a cancer treatment has been successful. So if the patient has a colon cancer and then they have treatment for it, be it radiation or chemotherapy or whatever, then after the treatment is over, they do a CEA, carcinoembryonic antigen. If it's low, then they know that the cancer treatments have been effective. Okay, so if a tumor, colon cancer, has been identified, there will be a surgery done to remove the affected portion of the intestines. If the ends of the intestines are reconnected after that partial removal of the area that's affected by the tumor, then we call the reconnection of the remaining intestine portions an anastomosis. Now, a colectomy is the removal of the diseased portion of the colon. If the patient has a hemicolectomy, that means that half of the colon is removed. Another surgical procedure is the abdominal resection or abdominal perineal resection, and this is, of course, performed for cancer in the rectum or the lower sigmoid colon. It's quite an extensive surgical procedure where the part of the colon, the entire rectum, the anus, and the regional lymph nodes are removed. There's an abdominal and a perineal incision for this procedure. And because of the nature of the surgery, of course, the patient would require a permanent colostomy. Other adjunctive treatment, preoperatively, intraoperatively, or postoperatively, radiation and chemotherapy may be given, especially for cancer of the rectum. So they use the radiation or chemotherapy to affect the maybe the size of the tumor and help it to shrink the mass so it's more easily taken out surgically. If there's metastasis present, the patient is usually treated with chemotherapy. If metastasis has occurred, oftentimes it may go to the liver, and then they may do intra-arterial chemotherapy directly into the liver to treat that metastasis. We're not really going to get into the specifics of the chemotherapy because that's more of a specialty, but just so that you realize that there is chemotherapy available. Now, they could do chemo preoperatively, radiation preoperatively to try and treat the cancer, bring down the size of the mass, etc. If they have surgery first to remove the mass, and then they pre or post-operatively give radiation or chemotherapy, they have to usually wait a few weeks before they can actually start that treatment until the surgical incision starts to heal. Otherwise, we may be causing more problems by giving them the radiation. It'll slow the healing and maybe set back the patient quite a bit. As far as nursing management goes, for patients with surgery related to cancer of the colon, of course the abdominal assessment has to be done. Let's see, we're assessing for bowel sounds post-operatively, for any distension. We look at the colostomy if there's an ostomy done. Does the colostomy site, is it beefy red, or is there signs of, problems with circulation, things like that? So we certainly do monitor the patient closely after they've had surgery for colon cancer. Okay, in this picture you can see the advancing stages of a colon cancer. A stage 0 or stage 1 is pretty superficial. A stage 2 involves more localized lymph node involvement. A stage 3, again, more extensive lymph node involvement. And a stage 4 colon cancer then would, of course, have spread to other organs throughout the body. Okay, now let's take a look at the different types of colostomies. Colostomies are identified by their location and whether 1 or 2 lumens are visible. So if we're looking at a loop colostomy, during the surgery, a loop of colon is brought through the abdominal incision and onto the surface of the body. Then an open or a laparoscopic approach can be used. The colon is transected and the edges are sutured to the abdominal skin. And then an appliance for collection of fecal matter is attached over the entire exposed colon. So there's kind of a loop, that's brought forward to the abdominal surface. A double-barreled colostomy, in this case there's 2 separate stomas. The loop of the intestines is completely severed, creating a proximal stoma and a distal stoma. The proximal stoma is one closer to the small intestine, so that is the one where the fecal material is going to pass through. The distal stoma leads to the rectum and discharges only small amounts of mucus that's produced by the intestines. The distance between the stomas can vary. If they're too close together, it's difficult to get a good seal for the collection device around each one. This type of colostomy is usually done when there's plans to reattach the ends of the colon in some future surgery. A single-barreled or end colostomy, there's only one stoma, and the end is brought to the abdominal surface, cuffed over, and then sutured to the skin. If the colostomy is temporary, the remaining portion of the bowel and rectum are left intact. If the colostomy is permanent, such as in the abdominal perineal resection, then the lower intestines and the rectum and anus are removed. In some cases, the rectum and anus are left intact and will continue to produce mucus and expel it from the anus, but there won't be any stool coming from that area. Okay, locations of colostomy. There's several different locations. An ascending colostomy is one in which either one end or the loop or portion of the ascending colon is brought to the surface of the abdomen to form a stoma. Ascending colostomies are usually temporary. Then we have the transverse colostomy, where it's situated toward the middle of the abdomen, where the location of the transverse colon would be. This also is usually a temporary colostomy. The stool from the transverse colostomy is soft and is discharged unpredictably. A sigmoid or descending colostomy is located in the surface of the lower quadrant of the abdomen. It is the most common type of permanent colostomy and is usually done to treat cancer of the rectum. The stool from a sigmoid colostomy is more solid and well formed and may be discharged no more often than once a day or every couple days. It's therefore easier to establish a pattern for evacuation. And then we have an ileostomy, and it's performed to drain fecal material from the ileum. It's indicated when disease processes or trauma require bypassing the entire colon. The most common indication for an ileostomy is chronic irritable bowel disease, malignancy, or any other like inherited colon disease where polyps have a high potential for malignancy. So they have to be careful where they select the site for the stoma, because the stool from the ileostomy is completely liquid and still has a lot of digestive enzymes in that type of drainage. So it can be the drainage can be highly irritating to the skin, and it can be real difficult to get a good seal on the collection device. So it's really important to focus nursing care on protecting the skin and to teach the patient long-term management of how to protect the skin around the stoma. The surgeon has several techniques that they can use. There's called a pouch ileostomy or a continent ileostomy, where a small segment of the ileum is looped back on itself to form a pouch, otherwise known as a cock pouch, and a nipple is created from that pouch. So pressure from accumulating feces closes the nipple valve and prevents the constant drainage from the stoma. The patient then empties the pouch every 3 to 4 hours during the day by inserting a catheter into the stoma. However, not every patient is a candidate for that type of technique. The preferred procedure for ulcerative colitis is the creation of a pouch from the terminal ileum, and this pouch is sutured directly then to the anus. And the anal sphincter is left intact and functional. So the patient can still pass stools normally, only they're going to be extremely liquid. There may be some fecal incontinence, especially during the night. Procedure is usually performed only on patients younger than 55 years of age who don't have any anal sphincter deterioration. The nice thing about this procedure is it eliminates the need for any external appliance and is a more natural way to handle waste. Okay, so here you see a picture of a loop transverse colostomy. So you can kind of see how the intestines is kind of brought out, and a loop of the intestines is brought out to the through the abdominal wall, and then the slit is cut, in that loop of intestines, and that's where the stool comes out. You'll see there's a bar that's located underneath that loop of intestines, and that's used to keep the intestines from slipping back through the abdominal wall. And then here you'll see different types of ostomies and intestinal diversions. So we've got, first of all, the ascending colostomy on the upper left-hand side, the double barrel colostomy where we've got two stomas again, and either one of these is usually done when the colostomy is going to be reversed. Then on the lower left-hand side you see the descending colostomy, the sigmoid colostomies in the middle, and then the ileostomy you can see is coming off of the ileum, and the ileostomy is the one located on the right-hand side on the bottom. You can see that the ileostomy is of course going to have much more fluid drainage, and then the other colostomies, as they get closer to the rectal area, are going to have more solid types of stool draining from their colostomies. Here you see examples of the cock pouch, the S-shaped reservoir, and the J-pouch reserve, where the patient does not have to wear an appliance outside of their body. There are reservoirs that are constructed within the patient themselves that collects either the stool, or in the case of the J-pouch reservoir, the stool is drained out through the anus, through the rectum and then the anus. Okay, the pre-op nursing care of a patient who's going to have a colostomy procedure done. They may be on a low residue diet as early as 7 to 10 days before surgery. The last 24 to 72 hours before the surgery, the diet is changed to clear liquids only. Vitamins and minerals may be given to supplement these restricted diets, and antibiotics may be given prophylactically to fight against infection at the operative site. Patients may have laxatives or enemas to clean out the colon. In some instances, they may have an antibiotic type of enema given to clean out the flora in the intestines. And prior to the surgery, or even after I think the patient is put to sleep, they may have a nasogastric tube inserted to decompress the stomach, the GI system. Then immediately post-op, of course, you would be monitoring vital signs, etc. You would, of course, be assessing the surgical site, checking the stoma to make sure it's beefy red and has good circulation, maybe listening to bowel sounds, monitoring the IV fluids. Patient should be assessed for nausea and treated early with nausea, because we don't want the vomiting to place undue strain on the suture lines of the colostomy. We keep track of intake and output and monitor fluid balance. Psychosocially, the nurse assesses the patient, especially for their perception of their altered body image. Need to assess their usual coping skills and the emotional state. What support systems do they have, and what was their pre-surgery lifestyle like? Oftentimes our patients are referred to ostomy support groups because they have information on clothing and products and things like that available to them. As far as diet, the patient is started on liquids as soon as they can tolerate it, and the diet is advanced slowly. As far as care of the stoma goes, we inspect the stoma. We would expect it to be pink or deep red in color, which indicates adequate blood supply. It should look like a healthy mucous membrane. There may be slight bleeding around the stoma initially, but not any more than slight bleeding should be reported. We would check for any color bleeding through the collection device, because the collection device is see-through. Dark purple or black stoma color should be reported immediately, and the skin around the stoma should be evaluated for any irritation or signs of breakdown. Fecal output from the colostomy does not occur for 2 to 4 days because of the bowel evacuation in the pre-op prep and the clear liquid diet post-operatively. A surgical dressing is never placed over an ileal stoma. If there's a significant decrease in ileal output followed by stomach cramping, the ileum could be obstructed, so those symptoms need to be reported to the physician immediately. Again, measurement of intake and output is extremely important, especially with the care of the ostomy patient. We always watch for signs and symptoms of dehydration in anybody, especially people who have ileostomies. Once the patient is eating, again, the ileostomy drainage is usually emptied every 2 to 3 hours. The pouch should be emptied when it is half full. The patient, eventually should be taught how to empty their drainage pouch on their own. If they have a continent ileostomy, such as a cock pouch, a drainage tube is inserted with gravity drainage to maintain in the immediate post-operative period to prevent distension and allow the pouch to heal. And then in about 2 weeks, the patient is taught to insert the catheter into the pouch to drain the contents. We need to consider patients' cultural issues. Examples that are in the textbooks are the Jewish observance of Shabbat, which strictly forbids the use of running water or electricity during that time. So hygiene must be accomplished before the start of Shabbat. And a Muslim patient may observe a strict fasting practice for Ramadan that lasts 28 days, in which no food or fluid is consumed between sunrise and sunset. So if a patient has an ileostomy, that could definitely put them at risk for dehydration. Or a change in eating patterns could lead to diarrhea or constipation. As far as peristomal skincare goes, drainage from an ileostomy contains enzymes and bile salts. We talked about that before, and that can be highly damaging to the skin. So the area of skin around the stoma has to be kept clean and protected. Fecal material should not be allowed to seep around the opening of the collection device and pool on the skin. This pouch should not be changed more than necessary to prevent trauma to the skin, especially in the immediate post-operative period. The 2 major principles to follow are to protect the skin and prevent contact between the skin and discharge from the stoma. You may provide a protective barrier to prevent contact between the skin and the discharge from the stoma as well. So there are some devices out there and creams and things that can be applied that will prevent skin breakdown. Appliances are generally changed twice a week because we want to maintain an effective seal. If the device, of course, starts leaking, we have to change it. When the appliance is changed, we remove it carefully and the skin is washed gently with soap and water so the skin is not damaged by vigorous rubbing and scrubbing. In humid weather, a hair dryer or on a low setting may be used to dry the skin. Then, after cleansing, a protective skin barrier can be applied around the stoma, and then the collection device can be reapplied. As far as psychosocial concerns, again, The patients may go through the stages of grief and loss. We talked about that when we talked about the cancer section. As soon as the postoperative pain is controlled, it's best if the patient can talk with another person who has adjusted to their ostomy. And there are ostomy support groups that are available in the area. Many patients have concerns about odor, leakage, and noise from passing of flatus through the stoma. So the nurse and patient should work together to explore changes in lifestyle and realistic alternatives, maybe changes in diet, things like that. Again, the ostomy support groups are great resources for education as well. Important areas to focus in on for patient teaching are preventing intestinal blockage for the ileostomy patient, and what to do when there is a blockage in the intestine or the ostomy. What measures can be done to prevent intestinal blockage? Eating 6 small meals a day, eating a soft diet, chewing foods very thoroughly, adding foods slowly after the postoperative period. You want to add foods slowly to your diet. Drink more than 8 cups of fluid per day, and avoid dried fruits, corn, nuts, sunflower and other seeds, sausage and food casings, apple peels, oranges, pineapple, raw cabbage, celery, Chinese vegetables, coconuts, and mushrooms. And if the patient experiences a blockage in the intestines or the ostomy, begin a clear liquid diet. Cut the opening in the faceplate of your ostomy device a little larger than normal because the stoma may swell. Take a warm bath to relax the abdominal muscles. Massage the abdomen and area around the stoma to try and get the blockage to pop out. Try different body positions such as knee to chest position to move the blockage forward. Take oral enzymes to encourage digestion. And if you have a blockage or no stomal output for several hours, call the healthcare provider or intrastomal nurse to report the problem. Do not try to lavage the ileostomy and do not take laxatives. And if you can't reach your healthcare provider, then go to the emergency department and take all your pouch changing supplies along when you go to the hospital, because the hospital may not have the same types of supplies that you need. Okay, so let's look at this case study. Your patient, age 26, has frequent bouts of diarrhea associated with emotional and physical stress for more than 10 years. She is admitted for possible ulcerative colitis. The gastroenterologist feels that she has ulcerative colitis and would benefit from an ileostomy. Previous treatments have had no lasting effect on the patient's symptoms. The patient is 35 pounds underweight and currently has severe diarrhea and fluid deficit. What questions would you ask your patient on admission? So we might want to put this presentation on pause for a minute and try and think about what questions would you ask your patient. Questions such as, how many bowel movements do you have a day on average? Does any relative have ulcerative colitis or Crohn's disease? Because that's genetic. Do milk or milk products give you any problems? Do you have diarrhea if you eat a lot of bread or pasta? Have you been out of the country recently? Have you ever seen blood in your stool or had rectal bleeding? How do you usually cope with stress? What do you see as being stressful in your life right now? Do you exercise? What do you do for relaxation? What should be included in the patient's nursing care plan regarding assessments and interventions? So you might want to put this recording on pause for a moment and think about answers to this question. observation of the patient's bowel movements, amount of fluid loss and signs of dehydration, appetite and amounts of food eaten, and daily weight, and monitoring the condition of the perianal region should be included in her care plan. What are the benefits of having an ileostomy over alternative of having continuous bouts of severe diarrhea? So you might want to put this on pause for a second and think about the benefits of having an ileostomy as over an alternative of having continuous bouts of diarrhea. May prevent fecal incontinence accidents, may alleviate the pain, might make it easier to control fluid and electrolyte balance, may be able to have a more normal lifestyle and be able to work once healing and adjustments have taken place.